Okay, it is now my great privilege to introduce our speaker today. Dr. David Kopacz is a psychiatrist in primary care at the Seattle VA and a national education champion teaching whole health to VA staff. He's a clinical associate professor at the University of Washington. He's board certified in psychiatry and integrative medicine and is a meditation and yoga teacher. David is an artist, poet, and author. He has co-authored the chapter on clinician resilience in the integrative medicine textbook. His most recent books is Caring for Self and Others, Transforming Burnout, Compassion, Fatigue, and Soul Loss. He has also collaborated with Joseph Rael, also known as Beautiful Painted Arrow, on a number of books and articles. I highly recommend them. I've read them all. In articles including Walking the Medicine Wheel, Healing Trauma and PTSD. I might also add that I've known Dr. Kopacz for years now. Outstanding clinician, compassionate provider, real thought leader in the field, and just a great sense of humor, which may be my favorite quality. So, and like I said, it's a privilege to call him a good friend of mine. So I'm going to exit stage left now and turn it over to Dr. Kopacz.
Thanks a lot, Brad. Appreciate it. Okay, welcome everyone. We're going to be talking about burnout and telemental health today. And to start out, why don't we look at some of the benefits and costs of telemental health? Anybody who's done virtual video or audio telemental health is going to be quite aware of these. But some of the benefits are flexibility for both the provider as well as for the patient, decreased commute time for patients and clinicians, increased accessibility for patients. The first telemental health I started doing in 2019 was on a project that Brad had started, a rural Native veteran project, doing outreach to Native veterans out in kind of away from the urban areas. And so we saw how that could really help bring care out into rural areas. You also have an ability to personalize your workspace that you don't in many other offices, particularly at the VA. There's not a lot you can do in the VA to make it less institutional. You can also at home take exercise breaks, nature breaks. During the pandemic, when I was working 100% virtually, I kept a bird book by my desk because looking out into the back window, I saw all sorts of birds I'd never seen before, different migrating warblers, and I really felt more connected to the changing seasons working at home and being able to look out the window while I was working. You can take breaks with family, breaks with pets. However, there's a lot of costs of mental health, telemental health. There's isolation. By definition, you're 1 degree removed from your office space and 1 degree removed from wherever the patient's located. This can also lead to emotional disconnection, both from the team as well as from the people you're working with. You're constantly using technology as a mediator, and technology can be glitchy. It can have updates. It can have different things that go on that you can't figure out. Either you or the patient might not be able to connect to video or might have poor audio quality. And this means that you're not just in communication with somebody, you're always aware that there's a medium that you're communicating through that's different than if you're just talking to someone one-on-one. There's an issue of cognitive overload or Zoom fatigue, as it was called. And also, I came to think of it during the pandemic as homing from work at some point. I felt like I was more like I'd periodically do my homing stuff, but I was mostly at work. So, how do you create this sort of distinction between your work and your home when you're working from home all the time? I mentioned some of the technical challenges that can interfere with clinical time. And there's more sedentariness that's a risk. I was using a step tracker and I was amazed at how many more steps. I get about 2,000 steps more a day just going into work and walking to the bathroom, walking in and out, walking down the hall. So a little more physically active at work than I was at home, unless I really made a concerted effort. So we're balancing all these benefits and costs. And some patients feel that the benefits outweigh the costs. Other patients really want to be seen in person. Same for providers. Some like it and some don't like working virtually. So let's look at differences between human connection and technological connection. With human connection, we start with body to body. So when you walk out into the waiting room, you might shake hands with someone. When somebody's sad, you might, touch them on the shoulder. You're in their physical presence. The two of you are together in the same space. There's also emotion to emotion connection, which I always tell providers, and when I teach psychotherapy to residents, I tell them, you can only connect to another through your own emotions or your own mind or your own heart. So you have to develop these connections yourself, these self connections, in order to connect with others. So we can connect emotion to emotion and mind to mind, but also heart to heart, and bringing in compassion and caring into our interactions, not just the technique that we're doing, but bringing some humanity of ourselves and spirit to spirit. And I don't mean this religiously or metaphysically necessarily, but the having inspiration, having motivation, having energy, vitality, connection, all these things we could think of as coming through kind of spirit and soul. And we talk about this in the VA. We'll get to a slide on this later. And on the other hand, we have technological connection. We have wired connections. We have Wi-Fi's. Actually, I saw this joke recently. There's a new book on Maslow's hierarchy, like what Maslow was working on when he died. He died relatively young. And so there's this new book, and there was a picture of the new Maslow's hierarchy. And at the bottom, the foundational need of human beings was Wi-Fi. So Wi-Fi is the new kind of base foundation on this joke of Maslow's hierarchy. So we have audio and video connection, and these, again, there's ways that we can feel close to others through this, but there's also ways that it can distance us, or it can screen out different things that we wouldn't see if we were face to face with people. We've got a chat feature, but overall, this prioritizes mental connection, and it's harder for emotional. There's no physical connection that you can have really. Heart and spirit, those are more subtle. Those are harder to have as well, those types of human connections. So our burnout rate's higher for telemental health. This isn't an exhaustive survey of the literature, but just looking at a few articles out there, some say yes and maybe that burnout rates are higher. Others say no, burnout rates might not be higher, that the benefits outweigh the costs of being sedentary and working through the medium of telemental health or video. So what is burnout? This is the WHO criteria, and it's similar to Maslow's triad of burnout. And this isn't a disease or a disorder, it's an occupational phenomenon. It's a syndrome that happens from work. We can have feelings of energy depletion or exhaustion. We can have increased mental distance from our job, or feelings of negativism or cynicism, and that can lead to detachment and disconnection. And again, with virtual work, we're already one step removed. And so that can predispose us to feeling this disconnection and detachment that could then spiral into more of a full burnout. And we have a reduced sense of professional efficacy, meaning the more that we do, the more we feel there is to do, and that we can just be sort of spinning our wheels or going through the motions, but just unable to really feel like we're doing a good job or we're on top of things. So when I start talking about burnout to people, sometimes people would say, oh, that sounds more like compassion fatigue or secondary traumatization, or maybe it's this, or maybe that's moral injury. And so I thought there's something nice about being able to, hone things in and have these very specific, distinct syndromes that we're talking about. But there's also something good about being able to talk about in aggregate the holistic view of suffering that happens through the costs of caring. The work that we do is difficult. We work with suffering people. Suffering affects us. We're wading into suffering. And so, at some point, we're going to feel that suffering ourselves. So there's all these different kind of components that I think about as of the cost of caring: burnout and compassion fatigue, the different traumatization disorders, secondary traumatization, where when you're working with someone who's traumatized, you can start to take on some of that trauma feeling or that mistrust of the world, or the sense of vulnerability that traumatized people have. There's actual post-traumatic stress disorder that people can experience from clinical work. Demoralization is kind of similar to burnout, the feeling of just, a lack of drive, a lack of feeling you're making any difference, just a feeling of, kind of loss of morale. That's a good way of putting it. And this can also lead into moral distress and moral injury. And this is an interesting part of the cost of caring and a counterpart to burnout. Moral injury could be something like you've got one ICU bed and you've got three sick people in the ER, and you have to decide which one gets the bed. And then you have to live with it if, there's bad outcomes. So during the pandemic, we really saw this idea of moral injury as part of clinical work coming to the fore. But there's also a way of looking at moral injury as something that's caused institutionally, whether it's by policies of the institution, or even just think about how much the electronic medical record intrudes into our work and interferes with our ability to connect to people. And so an idea of moral injury could be, we know we could help someone, but we just can't do it because of the way that we're supposed to work, or limitations on our ability to work. And then I think of soul loss too as another way of thinking about burnout. When you think about burnout and what it is that might burn out, like what happens, something's alive and flaming, and then it burns out. I started thinking, well, maybe it's our soul. And again, not religiously or metaphysically, but our sense of vitality and meaning and purpose, the thing that helps us connect to ourselves and connect to others. And when we lose this and all of these different costs of caring, suicide can be an outcome. And unfortunately, there's a far too high rate of suicide for doctors and healthcare workers. So this isn't just something that people feel a little bit bad and they should suck it up and keep working. It can actually lead to, loss of life for healthcare workers. So the pandemic, anyone remember that? March 2020, there was a 4,347% increase in telehealth that happened in that month. It's an amazing transformation that we did in healthcare. And, some of the different things, it was exciting at first, but there was also a lot of stress. I remember one day at 8:15, I felt like just opening all these different platforms and trying to get things working. I felt like I just burned out, like my brain just felt like it used up all its energy, 8:15 in the morning. And I texted my nurse and said, Jenny, I don't know, I'm done. It's 8:15. I don't know how I'm going to get through the day. Or I remember a veteran out on the peninsula, and I was doing a telephone call, and it was a really bad connection. I had to ask him multiple times. I kept having to say, I'm sorry to ask you this again, but did you say you are suicidal or you are not suicidal? And, it was a really bad feeling, this feeling of helplessness of here I'm asking this guy these really personal questions, and the audio is kind of going in and out, breaking in and out. So quite a challenge that it's been in the pandemic. And when we look at research on burnout and telehealth, we also have to look if whether we're also getting elements of the pandemic that are factored in as well. Because telehealth during the pandemic was two things. It's telehealth plus we're also dealing with the pandemic. So is the pandemic over? In 2023, the American Psychological Association said that they put their annual report of stress in America out, and they said we're a nation recovering from collective trauma. And they said there's a superficial characterization of day-to-day life being more normal, but it's obscuring the post-traumatic effects that have altered our mental and physical health. There's mounting evidence that our society is experiencing the psychological impacts of a collective trauma. And this was not just the pandemic, but they also identified global conflicts, racism, racial injustice, inflation, climate-related disasters, all these weighing on the collective consciousness of Americans. And their 2024 report was a nation politically divided. So again, more kind of collective trauma that we may be going through, and difficulty kind of coming together as a culture and a nation to deal with the issues facing us. So this is a graphic from the Institute for Collective Trauma and Growth, looking at sort of some of the different phases that they've seen in dealing with collective traumas. There's a sudden impact, and for the pandemic, and everything that's been happening in the country and the world, there have been multiple sudden impacts. So how do we even graph this out? Because we keep having more and more traumas and stresses going on. But there's this heroic phase where we kind of rally and we say, oh, it's exciting. We can pull together, we can help everyone. And then a disillusionment phase. And then the rebuilding phase, it's not just like the trauma is over. It takes a long time to rebuild and restore ourselves and our institutions and our sense of trust in the world, the feeling of safety in the world after the pandemic, and the feeling of connectedness with other people. And the Institute says this can take 2 to 5 years to go through this entire process. And then one thing I like about them is they talk about the wiser living phase, where we can actually function at a better level, a higher level, coming out of a trauma. So this is one type of resilience, a resilience that doesn't resist suffering, but a resilience that grows stronger through suffering. And this is something I've been thinking about. Everybody's working on burnout. Everyone's got different ideas about burnout. How do we prevent it? How do we build more resilience? Maybe we should talk about resilience instead of burnout. Maybe we should talk about compassion fatigue instead of burnout. So there's all these different variations, different ways that people think about it. We've still got burnout. So I kind of think maybe we should shift and say burnout is a fact of life when you're working with suffering people. And then the issue is not so much how do we prevent it? It's great if we can prevent some, but really, how do we grow from it? How do we go from burnout into post-burnout growth, analogous to post-traumatic growth? And my friend Lucy Houghton and I have been thinking about this concept, post-burnout growth, and looking at how people can go from a traumatic or a sort of negative, painful experience or suffering and grow from it or grow through it, to go from dehumanization to rehumanization, demoralization to remoralization, soul loss to soul recovery, and suicide to finding meaning and purpose. So we could think each of those costs of caring are kind of in a dialectic, or they're sort of charting out a spectrum where we're periodically going to dip into one phase, and then that's an opportunity for us to grow the corresponding phase. So going from burnout to post-burnout growth. So we're going to shift a little bit here, talk about Cal Newport, who's written a lot of books on technology. And he's got a book called Slow Productivity, The Lost Art of Accomplishment Without Burnout. And so he thinks about this idea of slow productivity, and he gives 3 points of what that is. It's do fewer things, work at a natural pace, and obsess over quality. And he contrasts this to pseudo-productivity, which is the use of visible activity as the primary means of approximating actual productive effort. So that's the whole book, is basically that, looking at how taking your time can lead to a better outcome and better quality. Yet our whole society is obsessed with efficiency and productivity. And we know that in healthcare. We hear this all the time about efficiency and productivity. We don't hear really about compassion, caring, about the quality of the interaction. We hear about the throughput. How many patients did you see? How many RVUs did you have? And so Newport says we need this different kind of productivity because there's a relentless overload that's wearing us down, and it's generated by a belief that good work requires increasing busyness, faster responses to email and chats, more meetings, more tasks, more hours. So in a way, saying we need a cultural shift. We need to stop thinking that busy is better and start to see that busy can actually not only is it not better, it might be worse. There might be worse outcomes sometimes. So here's a few of the applications that I gleaned from his book on slow productivity. In healthcare, maybe we can do some of these, maybe we can't. Simplify your workday. One thing I try to do is to make sure things are in blocks so that I'm not doing 5 different things in a day or 5 different things in the morning, to try as much as possible to, do 1 or 2 or 3 things instead of having it so scattered. Try to focus on one task at a time, because that's how the human brain works. And he reviews some of the neuroscience research on concentration and attention and technology. Double your project timelines. Just Whatever you think it's going to take, think it's going to realistically take twice as long. That gives you more breathing space. That's hard to do in a lot of situations, like at the VA, where we've got these imposed timelines. Forgive yourself for not making deadlines, using sort of self-compassion and forgiveness. Limit your missions and projects and daily goals. Just dial back on what you think you're going to get done each day. Pay attention to your surroundings in a positive way, to use your surroundings to create kind of a healing space for yourself, or a supportive space, so that you can feel supported by the things around you, and to take breaks into your surroundings, and to create rituals, particularly rituals of well-being, but also just even rituals of how you're going to deal with your email. There's a lot of people who will say you should only touch an email once. Don't open a bunch of emails and then say I'll come back to them later. But when you open one, go ahead and work with it, and complete one thing instead of moving on to the next. So there's a few different things that he talks about. Again, some might work in healthcare, some may not. Here's another interesting perspective. Greg McEwen in the Harvard Business Review says, to build a top performing team, ask for 85% effort. He says maximum effort equals maximum results is an outdated way of thinking about peak performance. It might be good for a sprint, but that's not a long-term goal. And he says research doesn't actually show that it works. He says what works is an 85% rule, that to reach maximum output, you need to refrain from giving maximum effort all the time. It's a more sustainable approach. So I just think this is another interesting perspective that is complementary to the idea of slow productivity. Okay, we've got a selective attention test here. Let's pay attention. The directions will be given here as we go through it. So I'm going to go ahead and play this here, and let's watch.
This is a test of selective attention. Count how many times the players wearing white pass the basketball. How many passes did you count? The correct answer is 15 passes. But did you see the gorilla? This video is from research by Daniel Simons and Christopher Chabris and is copyrighted. It is available for use in talks, training, and teaching on.
Okay, I'm not going to stop sharing now, but we'll go in the question and answer part. We'll kind of talk about this. I'm curious to see how many people saw the gorilla, like if this was your first time watching the attention test. They did this in research, and here's what they
on
found.
DVDs from.
Oops, there we go. About 50% of people don't see the gorilla. This is a 1999 study, and they talk about the idea of selective inattentional blindness, or sustained inattentional blindness, meaning when our brains are hyper focused on something, we don't see other things. Our brain works, and our perception works both by taking in the whole and also reducing down to the part. And a lot of what we're doing in our jobs is we're reducing people down to parts. We're screening for 5 out of 9 symptoms of depression, or we're ticking boxes, or we're trying to decide, do I need to complete a suicide eval or suicide support plan on this person or not? Where am I going to refer them? There's all these different things going on in our minds, and they may interfere with actually being present with the person. And another group redid this, and they put a gorilla figure 48 times the size of a typical lung nodule on x-rays, and 83% of radiologists didn't comment on the gorilla in the pulmonary field. So they applied this to a practical situation in medicine, and showed that even in clinical settings, people don't see things because they're focused on other things. They're trying to look what they think they'll see, look for what they think they'll see, instead of seeing what's actually there. And Shabri and Simmons, they have a whole book on this too, The Invisible Gorilla. And this leads to the idea of the myth of multitasking. And this is another book I drew on some for this talk, Leonard and Mednick, Humanizing the Remote Experience Through Leadership and Coaching. And they spend a lot of time looking at the differences that happen in human beings when they're next to each other. That's the next slide. We'll get to that in a minute. Let's focus on the myth of multitasking. People see, I was just trying to do it. I was trying to do two things at once. I didn't mean to do that on purpose. And I forgot to talk about what's right in front of me. The myth of multitasking. By attempting to do two things at once, people make approximately twice as many errors and take twice as much time overall. There's also research that shows every time you shift from one task to another task, there's a pause period where your brain's trying to reorient and you lose time. It's kind of downtime when you're shifting tasks frequently. And other research has found that individuals who are high multitaskers have slower reaction time and they're worse at filtering out irrelevant information. So that gorilla test is a multitasking test. We give you one thing to focus on, and then another thing happens, but some people can't shift off the one thing that they're focusing on. And it may be that the more you can hyper focus as a technician, as a clinician and technician, it may mean that you're less likely to see these other things, the human things that are right there before you, in front of your eyes. Okay, so here I was going to talk a little bit about Leonard and Mednick's book. They look at some interesting things. Eye contact, direct eye contact, increases oxytocin. So they say that you can't have that when you're virtual. It's difficult to make direct eye contact because you're supposed to be looking at the camera rather than looking down at the person's eyes on the screen. And particularly if there's a big group, you're looking down at the whole panel and looking at somebody in the corner there instead of looking up at the computer. So these are some of the things that in their book they say are contributors to cognitive overload and burnout. Decades of research shows that it's higher cognitive load to do video work than other forms of remote work like telephone. You've got more different factors coming in visually. There's more things that you're paying attention to. There's just more potential interference. So tech difficulties on either side with drops in the video feed, sound delays. Maybe we're having some of those even today. My internet was a little wonky earlier, so that's also just demonstrating the challenges of doing virtual work. And then on the computer, there's so many, I don't know how it is wherever you all work, but at the VA, we've got constant notifications and alerts, windows opening and closing. We do team, like when we're doing like triage, where we're like watching these spreadsheets and monitoring multiple different Teams channels. I mean, it's almost like you couldn't design a better test for multitasking and cognitive overload. Also, another thing with video compared to telephone, sometimes I like telephone because I feel like my brain can relax because I don't have to sit still and try to and see myself and watch my image. And I don't have to try to look at the camera. I can forget about things and just concentrate or focus on what people are saying. And Leonard and Mednick review some research that said that people watching a video of a confession were worse at determining the veracity of the confession than they were if they read a transcript or if they just heard the audio. That there's something about watching the video itself that interfered with people's ability to discriminate as well. Also, overcompensation, where we increase our emoting and we talk 15% louder when we're on video. A lot of studies have found this. And like I realized the first time I told a joke online, it's really uncomfortable because you don't know, was that a terrible joke? I mean, Brad will tell you, usually it's probably a terrible joke, but still, some people might laugh even at a terrible joke, And so you don't know, did that joke just flop? Is anybody there? Did my internet cut out? What's happening? You don't have that feedback that you have normally in interaction with people. In meetings, usually only one person at a time can speak. So there's that interference. And so you have to, instead of feeling like you can just spontaneously be part of things, you have to raise your hand or you have to wait and try and see, is somebody else going to speak? Should I speak now? All the technology updates, particularly in early pandemic, it was just continuously learning new things. We'd use this billing code, then that billing code, all this different stuff constantly. And then all this lack of interpersonal connection, like with the direct eye contact and oxytocin for social bonding. But there's also more opportunity for misunderstanding, disconnection, exclusion, and shifts in the reward fatigue brain balance. This is an interesting thing. There's research that shows, neuroscience research, that when you're feeling empathy for someone, meaning you're feeling what they're feeling, your brain will light up the pain circuits in your brain. When you're feeling compassion for someone, which they define as empathy, plus having some action, reward circuits light up in your brain. So, I mean, this is a profound thing because it means doing clinical work could actually be rewarding if you feel like you can do something. But if you feel like you can't do something or you're limited in what you can do, your brain's actually going into this empathy pain network that you end up feeling worse after a session rather than feeling better after a session. And maybe you've experienced this where you've had a really, really difficult session, but you feel like you and the person like connected at this deep heart soul level, and you came up with a plan, even though you didn't solve their issues. And you come out and you feel kind of, rejuvenated. You feel kind of energized from doing good clinical work. So it's not always just the clinical work. Sometimes it's just the time limitations, the inability to sit with people, and also to the fact that sometimes we don't know where we can send people to get them help. There's a lot of shortages with mental health treatment in the state, the country. So, okay, let's see what else here. Cognitive overload. Is cognitive overload brief burnout? This is something I just started thinking about as I was putting this presentation together. So burnout's feelings of energy depletion or exhaustion, this increased mental distance, reduced professional efficacy. So that day that at 8:15, I was like, I'm just done. I'm burnt out. I think what happened is I had cognitive overload, and then if the brain can rest, you can get that cognitive drive back. What is it? The uh, reward fatigue brain balance. Once your brain gets into a fatigue state, you got to do something to shift it out of cognitive overload and out of brief burnout. And I think a distinction maybe between cognitive overload is, if you stop working and you take a break, it sort of gets better. With burnout, even if you go on a holiday, it gets a little better and you come back, but then it comes right back again. Okay. Another thing I wanted to talk about, unfortunately, really quickly, which is ironic, is Slow Medicine, Victoria Sweet's book. So this is a really nice book that looks at critique of fast medicine, which is medicine as usual, what we usually do, and slow medicine, which is do the most important things first and let the others go. When you're with a patient, be with a patient. Don't be checking the computer or doing all this different stuff, filling out the forms that you need to do and the protocols and the tick boxing. Like be with the patient first, and then add the other stuff in. She came up with this idea of fast medicine and slow medicine when she saw her father go through a complicated series of admissions for health problems. And it seemed like everything that was done just made him worse because people weren't taking the time to read the record and to see, what his past was. So, Victoria Sweet says everything looked so good in the computer, and yet what father had gotten was not medicine but healthcare. So she makes this distinction. I'll sometimes make a distinction between a technician and a healer. And I think this could be also similar to the distinction between medicine and healthcare, which she defines as medicine without a soul. And by soul, she means everything that her father didn't get: presence, attention, judgment, kindness, and above all, responsibility. She says healthcare deconstructs a story into thousands of tiny pieces, pages of boxes and check marks for which no one is responsible. So if we were doing slow medicine, we would say, even in a virtual interaction, how can I bring in presence, attention, judgment, kindness, and responsibility? Because there's a temptation sometimes to think, as soon as I hang up, I'm done with this person. This person disappears when I close the window, you know. But how can we take responsibility to think, how can I help them connect to the next thing? How can I not just click them off or turn them off, but how can I actually be present with them and stay with them as they go through this journey in the healthcare system? So let's kind of go back to soul. You know, Victoria Sweet talked about there was a lack of soul in the healthcare that her father was getting. And Thomas More, a Jungian therapist, wrote a book a while back called The Care of the Soul. And he defined soul loss as emptiness, meaninglessness, vague depression, disillusionment, loss of values, yearning for personal fulfillment, and hunger for spirituality. And these sound a lot like burnout. So as I was kind of researching, you know, what do people say about soul and soul loss? And I'd compare them with burnout. And these really kind of map on this sense of like you can function, but your heart's not in it. You just don't feel inspired. You really don't feel you're disconnected. You can go through the motions, but your heart and soul aren't in it. So can we think about burnout as soul loss and our soul as a source of vitality, creativity, connection, passion, compassion, renewal? And think about what would help you reconnect to soul and bring it back into your work and your life. So, what do I think about with soul? So, what did you like doing as a kid? What were you passionate about doing as a kid? What kind of hobbies in your life have you let go of? Is there something you always wanted to do but never quite got a chance to do? Did you always want to take an art class or a language class or go visit a particular country? You know, what is the thing that on one level is the most important thing to you, and yet on another level is the thing that you always keep putting off? What's the most important thing that you could do first rather than getting your work done and then trying to do it? Because it may be that if you do this thing that your soul is craving, you'll have this energy then to deal with the work, and the work will become easier. So it's a little bit different way of thinking about resilience in the sense of um, instead of trying to prevent burnout, it's more about going toward your soul. You know, what is it that your soul craves? And at the VA, we talk about the circle of health, and we've got spirit and soul as one of the domains of what it is to be a human being. So we can think of these 8 different kind of later green circles as what it means to be a full human being, that we've got bodies, we've got our surroundings, physical and emotional surroundings, we've got lifelong learning, and we've got what we put in our body, there's how we rest our body, there's our relationships, there's spirit and soul, again, not religion necessarily, although it could be, but just what helps you grow and connect and feel alive. Could be being in nature, playing with your dog, playing with kids or grandkids. It could be, you know, painting or singing or listening to music. It could be anything that helps you feel alive. You know, what is that? How do you find that? And then using the power of your mind for relaxing and healing. So in the VA, when we work, and the beauty of this is not a disease-based model. This is a health-based model. It applies to everyone. In schizophrenia or with an antipsychotic, you only give that to someone who's got schizophrenia. You don't give an antipsychotic to your coworker, although sometimes you might want to. But with whole health, it's for everybody. Everyone has a body, everyone has spirit and soul, everyone has relationships. So this applies to everyone. And as a clinician, you use this first on yourself, and then you fill up your cup, and then you can give that to others. You can help connect to your patients through these different subcircles as well. So I'll give you one tool as we're kind of finishing up here. This is something that you can access online, the personal health inventory through the VA.gov Whole Health website. There's also a Live Whole Health app that's a free resource anyone can download. Because we're a federal organization, everything's open source. So as a staff member, as just a healthcare worker, non-VA, you can use this. Non-VA patient can use this. So it's open source and available to everyone. And we start with, this is a 2-page handout. We've got the circle of health, how your well-being is physical, mental, emotional, and your day-to-day life, just kind of an assessment of where's your baseline. And then we call this the map, this part down at the bottom. What matters most to you in your life right now? What's your mission, aspiration, and purpose? So what is it that's most important to you? Just how Victoria Sweet said, do that thing first. And with the soul, it might be do this thing first, because that's where your soul's going to be become sort of vitalized, and that will vitalize your whole life, your whole self. So what is it that matters most to you? Then the next page is just walking around the circle. Where are you now with your physical body? Where do you want to be? Where are you now with creating healthy surroundings, healing surroundings? Where do you want to be? And going around each of these different things just to get a little bit of a snapshot of looking at yourself as a 8-dimensional being and seeing how are you doing with each of these different domains. And there's times in our life where we get busy and distracted, or we're just really focusing on a couple things, and this helps us step back and reconnect to who we are as a whole human being. And then a couple things down at the bottom of like, what do you want to focus on first? Let's break it down. How would you start? And we talk about a SMART goal: specific, measurable, achievable, relevant, and time bound. So you want to run a marathon? That's great. How do you start that? Maybe you got to buy running shoes. That's the first thing. Or maybe you download something that's going to say what's your schedule over 6 months or 12 months to train for a marathon. So the idea is not to say something global. I want to have better health. It's I want to walk 15 minutes a day, 3 times a week. That's a SMART goal. So feel free to use this for yourself, or use it with patients or clients. It's a nice, easy tool that you can add in to an existing, even a busy interaction where you don't have time to talk about this. You can ask somebody, hey, would you fill this out between now and the next time that we meet? And I'll take a look at it. And we'll just see, what's most important to you. I want to know what matters to you, not just what's the matter with you. So, okay, I did pretty well there, I think, for the staying on. Well, it's a little later than I wanted. Okay, I'm going to stop sharing. Really curious to see how we get to the post when there seems to be no post, right? Because everything keeps happening. How do we get there? There's a philosopher, I might remember his name, who wrote that our lives are like living on a boat that we can never take into dry dock to fully repair. So we have to make these repairs while we're at sea, and we can never really make them fully. But that's kind of how life is sometimes, that there's times where we really have a lot of stuff going on. So I think that it's this idea of how can we shift from the pain to the compassion? What is there that we can do? Even if it's something we can do for ourselves, maybe we can shift to the reward circuit in the brain. Is there something we can do, even if we can't help this person in front of us? Can we volunteer? Can we do something in the world that helps us feel a sense of agency, and that we can try to make things better, even if it's on some small level? Or even doing loving kindness meditation. Loving kindness meditation, you're sending loving kindness and compassion to others. You're doing something, even though it's you sitting meditating in a room. It may be enough, if you practice it long enough, to shift into that reward place where you get a little bit more kind of brain energy and compassion energy to be able to get to that post place. But I would say it's requires an ongoing practice, just like yoga or meditation. It's an ongoing practice to try to get there. And once you get there, you can't stay there. You're always falling back, and that's the practice. Okay, next one, institutionalized demands for business and how to deal with that. That's a hard one, because if you've got a good leader, you can work with them to maybe see, is there a way that you can create more space, some more slow productivity or slow medicine within your own work life balance that you're trying to do. But we can't change leadership unless we're in leadership. We can bring things to people and to say, like during the pandemic, I helped out with our team lead, and we developed a team personal and professional well-being series that we did. So, that way I offered some of what I knew and worked with the team to kind of give this to the team during the difficult time in the pandemic. So there's some things you might be able to do that are creative, but there's limitations in jobs as to how much you can change the institution. So let's see, next one, neurotypes, autistic people appreciating. Yeah, so the individual variations, I feel that with shifting to phone, and maybe some veterans or patients, like the phone better because, oh, I think about this for PTSD too. There are people who talk about the unnaturalness of the video encounter, that your brain is seeing, I am right in this person's face. I'm like 3 feet away from this person. I'm in this intimate distance. And usually that intimate distance is for like family members, sex, violence. If you're going to fight someone, you're right in their face. If somebody's in your inner circle, they can be right up close. But that there could be part of the brain, and particularly for traumatized people, to say, this is in my personal space. But if you don't have to see the person, many people with trauma might feel more comfortable in the beginning because they don't feel that the brain's not getting more stimulation, just generic stimulation. Plus, it's not getting stimulation that could be translated as a threat. And so similarly for, autism and ADHD, somebody with ADHD might do better walking around the room. I actually do that when I'm on the phone. I'll kind of pace, I'll look out the window as I'm talking and kind of listen to the person and just, it's not doing stuff that distract me, but it's doing things to reset my brain to get it out of like a single-minded focus. And let's see. The 401 trainings.
Oh, I can answer that one. Yeah, the 401 trainings and the soon to come 501 trainings will be online and accredited for another year. So you have plenty of time to do that. It's just the 101, 201, and 301. If you want credit, you should do those quickly.
Thanks. And the New York Times article, I didn't see that, but I think this would depend, and it might be bimodal. At the VA, it's not necessarily our more affluent clients because I know that I reach a lot of people who are on VA disability, who don't have a lot of money, who live far away, who, would have to spend the night in Seattle. And so I know I'm able to reach them. But there's probably another group that's more tech savvy. You have to be a little tech savvy to be able to do video, and audio is still looked down upon. I really like doing audio too. But if somebody has a telephone, they could do an appointment that way. But video, yeah, I mean, if you're really down and out, you're homeless, you don't have a smartphone, you don't have access to video, then you're kind of out of the telehealth bubble or telehealth trend. Burnout and documentation, yeah. Gee whiz. I mean, documentation is just like it's never-ending burden. So I mean, sometimes taking a break can help. Sometimes if I take a break, like at the end of the day, or, this is one thing, if you to get out of cognitive overload, go take a walk, 5-minute walk outside, get some fresh air. You can do some deep breathing. You can do some breathing exercises. You can do some squats. You can do, some yoga. Just anything to kind of get your body moving, give your brain a break, help your eyes deep focus on, the 2, 3 feet in front of you. You can do a happy dance. So yeah, just do something, see if that helps. And sometimes I end up I take that break and I'm like, no, I'm really done for the day. I'm just gonna have to do my notes tomorrow, get up early, or they pile up. So, but taking a break can sometimes help because when you're in burnout, you can just end up slogging along and not being productive and just spending more and more time trying to do the same thing. Telehealth support group. I tried to do this during the pandemic and it was just so stressful. We couldn't get it together with some of my friends because it was just so hard to um, add one more thing on a Sunday night we were trying to do to add this kind of off the clock sort of support group. Ward. I mean, I'd look at that Leonard and uh, Mednick book for the brain fatigue, for discussion about that. And but also just any sort of shifting. You could look at the circle of health, and pick one randomly, even of I'm going to do something with my body, or I'm going to do something in my surroundings. I'm going to do something outside. I'm going to do something with food and drink. I'm going to do something with a relationship. I'm going to call someone and talk to them. You can try, kind of dialing around the circle to see if you can shift out of the fatigue to get more reward. But they do talk about that in this book, and there might be other terminologies that are used for that. Cognitive overload is one. Um, so you could look for that too, see what you find on that. Yeah, we went through all the questions.
Great. Thank you. Thank you again so much, David. The perfect timing. And this was a great talk, and I love the idea of doing a happy dance. And so I think we should send us all off to the rest of the afternoon and then the weekend with a happy dance, because this was just a great way to kick off the series for the year. So we appreciate it. Appreciate all of you who've joined us, and hope to see you next month, and keep in touch and have a great weekend. Thanks so much.
Thanks, everyone.